I'm going to restrict my talk to LDL. The first slide is, in an experimental animal, it is virtually impossible to produce an atherosclerotic plaque without LDL particles. Without cholesterol, you cannot produce hypercholesterolemia, you cannot produce an atherosclerotic plaque. And if you look at the mean levels of LDL is less than 1 millimole in pygmies, in Incas, etc. These are primitive humans who live only on animal diet. And their levels of LDL cholesterol is less than 1 millimole. 1 millimole is equal to 40 milligrams of LDL cholesterol. And so you see in the wild animals also. Only modern humans you see that LDL levels are more than 3 millimoles. So if you look at lipid metabolism, liver makes cholesterol and triglycerides and then packs them up in VLDL and releases them into the circulation. When it goes through the circulation, through the fat cells in the capillaries, lipoprotein lipase takes out the cholesterol, the triglyceride, and converts VLDL to IDL. And IDL loses some more triglyceride and becomes cholesterol-rich LDL. And LDL is removed from circulation by LDL receptor mainly on the liver. So the modern concept is LDL is the end product of lipid metabolism. It is not useful to the body at all. It has no physiological role. And the lower the LDL, the better it is for the person. So let me take you to some of the data. And what is the physiologic role of cholesterol? If the LDL is not useful, what is the physiologic role of cholesterol? If you see, cholesterol is involved in making from cholic acid in the liver, in hormone synthesis, skin resistance, cell wall component, etc., myelin sheath, and etc. But myelin sheath, etc. But how do these tissues get their cholesterol? They get their cholesterol by de novo synthesis. By de novo synthesis, it is not cholesterol which is circulating in the body. De novo synthesis, and also they get HDL cholesterol is the cholesterol ester donor. It is not the LDL cholesterol. So whatever tissues need cholesterol, it is donated by HDL cholesterol. So if you look at importance of lipid lowering, the LDL cholesterol lowering, you can see these are all the bodies which have given how to lower the LDL cholesterol. All of them go by risk assessment. First you have to assess the risk of the patient. Low risk, intermediate risk, high risk. And then majority of the recommendations determine the target LDL level, except ACC/AHA guidelines, which determines the statin intensity. So if you look at all the statin trials, these are all the statin trials, you can see in the green is the statin and in the blue is the control. There is approximately 25 to 35% drop in event rates. Event rate means stroke, MI, and death. Hard clinical endpoints are reduced by about 30% in the secondary prevention and about 20-25% in the primary prevention by statin. So if you look at, is there a lower limit at which LDL cholesterol, this doesn't happen? Look at the slide on the left side. I'm sorry, this is not working. Look at the slide on this side, left side. If the LDL cholesterol is more than 190, there are 34% chance of coronary events. And if it is less than 50, it is only 4.4%. And this was shown also in Jupiter trial, again on the left side you can see. If you compare Jupiter trial, 40, less than 70 and less than 50. The placebo has high event rate, less than 70, event rates are reduced, but less than 50, the event rates of mortality is reduced further 20%. So the concept is there is no apparent lower limit at LDL level at which there is risk reduction or regression with statins. So you can see that in the regression of statins, right up to 15 milligrams of LDL cholesterol, there is significant regression. And if you can see the risk reduction at 150 cholesterol is minus 29%, and at less than 50 LDL cholesterol is minus 56%. So it's very important that majority of the trials say that you should get the LDL down to less than 70 for high risk patients and also for secondary prevention. And if you can reduce LDL cholesterol but to less than 50 milligrams, you can halve the cardiovascular events. Therefore, it is very important, and you can see that 1% LDL reduction is equal to 1% reduction in the ASCVD. And the time for benefit, if you look at time for benefit for atherosclerotic cardiovascular disease, it is 1 year. For mortality, it is 5 years. The longer you give statin, the better is the outcome. And in experimental animals, it has been shown that if you LDL reduce to 30 milligrams, there is regression of atherosclerosis. There is complete regression of early atherosclerosis. There is partial regression of an advanced fibrotic mature plaque. Therefore, always the lower LDL works better with functional HDL. So what are the goals? Now in high-risk people, the goal is less than 70. Less than 70. Now the ACE guidelines have given another called extreme risk, that is those patients who develop events while on statins. Their LDL level should be reduced to less than 55 milligrams. That is what is the risk. But poor statins alone will not be able to do it. Slowly I cannot do it, and therefore you require at least in from Western literature about 40 to 50% of people even on high dose of statin don't achieve the goal LDL levels. Therefore you may need additional drugs. Additional drugs that have shown reduction in cardiovascular events is from IMPROVE trial. It has been shown that ezetimibe can reduce the events better. So in this trial they gave simvastatin high dose and simvastatin plus ezetimibe in the second group. The LDL cholesterol was reduced to 70 in the simvastatin group, to 53 in ezetimibe with plus simvastatin group, and there was further 16% reduction in the events. Further 16% reduction in the events with adding ezetimibe. But it is not a very good lowering of the cholesterol, and the best probably which is available is the PCSK9 inhibitors. Let me go to the physiology of PCSK9. This is the hepatocyte which makes LDL receptor. LDL receptor is that brown thing that goes and sits on the surface of the hepatocyte. When it makes this LDL receptor, it also makes an enzyme PCSK9 which is released into the circulation. When an LDL particle comes, it attaches to the LDL receptor. The PCSK9 also attaches. That becomes an endocyte, goes into the liver cell and combines with lysosome, and lysosome destroys LDL particle, LDL receptor and PCSK9 inhibitor. Whenever there is a congenital absence of PCSK9 enzyme, or if you give monoclonal antibodies to PCSK9, it is not available for attachment. So LDL receptor takes the LDL particle, goes into the cell surface, and when it combines with lysosome, it only gives LDL particle to lysosome, and receptor is recirculated back to the hepatocyte surface. There are many receptors and very low LDL levels. In those people who have congenital mutation, in which PCSK is not available, their LDL levels are 15, 14, 16, and they don't have coronary artery disease. So if you look at PCSK9 inhibitors that are available to us, the small interfering RNA, they are still making trials going on, but monoclonal antibodies, especially alirocubam and evolocubam, is available now. And just 1 minute. The foremost indications for PCSK9 inhibitors are statin intolerance, statin unresponsiveness, and hypercholesterolemia. Now the fourth indication is added, that is, if you don't achieve goal LDL with statin, add PCSK9 to them. And these are all the trials. Do I have time to go through one trial? Yeah, I'll just go through the Fourier trial. The Fourier trial, this is a trial in which they have given statins in patients for secondary prevention, CAD patients. When LDL is more than 70 milligrams, they have added the evolocubam subcutaneously weekly, monthly twice. And they found that if you give this drug, it reduces LDL levels from 90 to 30. And it reduces events, 16% reduction in the event at 1 year, 25% in second year. Therefore, this is a very important drug that has to be done, and all the fears that there can be neurocognitive deficiency with that has been proved wrong. Ebbinghaus trial has shown clearly that there are no neurocognitive side effects of Fourier trial. And so the future perspective is that if you give PCSK9 inhibitors, it's a treatment that is now available, and approximately all over the world, in America alone, there are 4 million patients who will require the PCSK9. In India, at the lowest estimate would be 15 to 60 million patients. Only problem is the cost. $10,000 to $12,000 per year is the treatment cost for this drug. And the last slide I just want to tell you, share with you, this is an important slide. The lower line is pharmacologically lower LDL, the upper line is genetic mutation lowering LDL. If you reduce LDL cholesterol to 18 milligrams, you get 7% protection against events. But the same genetically 18 milligrams will give 30% protection. Therefore, we are not close to nature, we still have a lot of work to do. Thank you.